report from the R&P committee.
Thank you, Chair. Since our last board meeting, first of all, the report covers 2 meetings held in April and May of the R&P committee. As you can see from the report, the key items were previously discussed at our last informal board meeting, where I reported the level of assurance was either substantial or moderate. Since then, I'm pleased to report that the level remains either substantial or moderate, but with the exception of a limited assurance given on the apprenticeship levy, which was discussed at the last R&P committee.
Yeah.
This is because we've not been able to get some of the training off ground due to COVID-19 and some of the administrative challenges that are faced by those particular teams. We continue to contribute towards the fund, which is 0.5% of the total payable, which amounts to about £16,300 per calendar month, on which we received a 10% contribution from the government, so it's about 17,000. Now, if we're unable to spend this money, there's a significant risk of funds, which is in the region of £31,000. There are some actions in place to spend some of this money before the due deadline. So, and that's the reason we have a limited assurance on that. The other item I'd like to report to the committee is on the financial position. As at month 1, I'm pleased to report that we have a break-even position as opposed to a deficit of £700,000, which we were projecting at the beginning of the year. The authority has received COVID funding of £500,000 and retrospective top-up funding from NHSI of 0.6 or 1.1 million, which has contributed to that break-even. The committee were informed that our budgets for months 1 to 4 have changed to reflect the revised financial plan as issued by NHS England, and I think Sarah will touch upon that in her report later on. I'm pleased to report that cash balances remain strong for the organisation at 20 million, but please note that this includes £6 million of early payments of the block income due to the change in the contract rules. As the board are aware that due to COVID-19, guidance has confirmed that we don't need to be focusing on our CIP programme just yet, but that doesn't mean say we're being complacent. Work is being done behind the scenes and that's being sort of discussed at the Benefit Realisations Group. Capital expenditure was £17,000 in the month of April, and the forecast for the year is 1.9. And I think Robert's working behind the scenes around that as to how we can progress our capital schemes with social distancing rules in place. I'm pleased to report that agency costs across the services have reduced and that we're well below our internal target, but also the NHSI ceiling target of 315,000. I'm happy to take any questions or Sarah if there are any technical ones. Thank you, Chair.
Thank you very much. A very good comprehensive report. Much appreciated, Harmesh. Right, Peter Featherstone. Well, in fact, both Peters, I think, are indicating, but Peter Featherstone first.
It is a minor query, and that is in regard to the apprenticeship levy. I know it's a small amount of money, but I suppose it's very important to those apprentices that we could bring on board. However, this is a national problem. I think to try and recruit apprentices during COVID-19 is tricky. I just wondered, and this might be a question for David, whether this is something that is recognised as a national issue and whether there might be an extension to this period that would be appropriate for all NHS trusts.
Could I just add at this stage that I raised that very point at the R&P and about the national and maybe using NHS providers as a vehicle for lobbying government to do just that. It's all about after 24 months you lose the money and whether that period should be extended. I absolutely agree with you, Peter, and we did actually bring that up at the R&P the other day.
Thanks for that, Peter. Jackie, I know you've got your hand up. Did you want to answer that point specifically? If not, I'll come to you later.
Yeah, well, yes, just to say that I attend a meeting weekly for HRDs nationally, which is chaired by Prerna Izar, the Chief People Officer, and she has a direct line in terms of clearly to government. So it has been raised in that meeting. We haven't got a response at the moment or any indication, but of course it is. I do agree it is a national problem. So.
Okay, thanks for that. Thank you, Jackie. Peter Phillips, was that your question as well?
It was. It was following exactly the same point as Peter Featherstone's.
Thank you. Thank you for that. So, Tina, over to you.
Thanks, Chair. Just on the agency spend, it's really pleasing to see that going down. We've been aiming for, and we might not know the answer to this, but do we think that is as a result of COVID and redeploying staff and in some services, or do we think it's more sustainable than that? We might not know yet.
It's this combination of a lot of factors, Tina, that we discussed at RMP. COVID is definitely playing a major factor in terms of getting people onto the apprenticeship scheme. Yes, you're absolutely right. But there are other issues as well. We could have done a bit better earlier on, but that doesn't mean to say we're not trying. There are mitigations put in place to get to spend that money by the end of the year.
No, sorry,
it's okay, Tina. So sorry, Tina.
Right,
I didn't mean to talk across you. I think your question was about the agency spend, and I think Steve was coming in on that one. Steve, did you want to answer the point on agency spend?
Yeah, so with respect to agency, I would say, Tina, that it's part and part. I think part is obviously we've redeployed people, and as you know, our agency spend is largely in community hospitals or some of the high kind of cost groups, so doctors, dentists, but in particular, I think it's part and part, and I think we need to keep a close eye on that as we start to restore more and recover more.
Yeah, thanks.
Thanks for that. Jackie, I think you were next. Can I ask colleagues, when you've had your question, make sure you put your hand down, because sometimes it's not clear to me if you have another question or...
Nuala, I don't, sorry.
That's Jackie, you don't either. So in fact, there are no questions in the queue at the moment. So can I ask that we all accept the assurance that we've had from that particular report from Harmesh, the report from RMP?
Yep, fine.
Yeah.
Okay, thank you very much. On to the next item, and I know Harmesh touched on some of it, but Ros, you may want to say more on the appendices. Do you want to make any further comment on the performance report?
I do, Nuala. There's just a couple of things. One is an apology for those who've read the papers with forensic detail. They will see that this makes reference to some appendices which aren't actually included in the papers. So my apologies for that. I hadn't spotted that until earlier on. I just assumed the bundle was the usual bundle that had gone to RPC. So I just, there's one thing I can say about that, and also I will make sure that the papers get updated after the meeting. There wasn't enough time for Louise to address that before we came online this morning. The metrics overall, so what is missing is our dashboard, our overall performance dashboard, and that was reviewed at RPC, and that is reflected in Harmesh's summary around the levels of assurance there. I would say that all metrics remain pretty much the same as we have been tracking them through in previous months, with one exception, and that was the access times. Now we touched on in the quality section of the meeting, and the information that's included in the quality report does make some reference to our RTT, our referral to treatment times particularly, and others. So that's the point that I wanted to escalate today, but also in the context of what we're doing next. So there's no surprise to anybody that while whilst we moved into the first phase around COVID response, that our elective care was suspended in line with national guidance. When you're looking at, I was looking at the access times for RTT yesterday, we do need to note that we've got a deteriorating position. Our non-admitted performance is now down to 37%, which is obviously a performance that we understand the context of, but is something that we've not experienced previously. That relates to around 380 people waiting over 18 weeks, and they are mainly our TEMS patients. I'll come on to the mitigations that are going on around that. So the 365 of the 380 are TEMS patients. Our open clocks, so those that are in sort of work in progress, for want of a better way of describing it, is down to 76%, and we are normally above the 95% on that indicator as well. That's 927 people, and again, the majority of those people waiting on that list, waiting in those terms, is MSK. So 750 odd of those people are MSK TEMS patients, but we've also got some dental and community peds waiters there. This isn't new news to us, and like I say, both committees have touched on this, but as we're at the point of restoring, it's important that the board understand that we are particularly deploying video conferencing techniques, apps and video conferencing facilities to engage with those people who are waiting in an appropriate way at this time. And I would expect to see those numbers recovering over the next few weeks. When we come on to, when we've looked at the COVID-19 dashboard that at the beginning of the meeting, what we are developing, and I know that it's being looked at this week, is a restore dashboard, and that the heavy emphasis on that will be around access to our services. So we will see an equivalent dashboard that will focus on those things that are therefore very important in terms of restoring. So that's the only sort of area of performance that I wanted to highlight to the board, and also just to give you some assurance that quality and safety clearly are keeping an eye on progress there, and that we will have a corporate dashboard view of recovery there, so that we can keep a track of that position as it improves.
Thank you for that, Ros. Are there any comments or questions for Ros on that report? David?
Yeah, on a very minor technical point, Ros, not only do we need to circulate that missing appendix, we need to put it online for the
yes, absolutely, well. Yeah. Whatever we have to do to just correct that, we'll do that after the meeting. Yeah.
On the more material point, obviously we're not alone in having a backlog of elective work. That's true of every NHS provider across the country, and it's going to be a huge focus of the next phase of recovery for the NHS. The context is obvious. The constraints. So simply using video technology won't be enough, I don't think.
No, that's right.
It will help. I think it will stop it getting worse. I'm not completely convinced it will retrench our backlog for us, or indeed anyone else. So the obvious dilemmas are going to be, how fast can we get full service restoration back in place? The constraints are both staffing and PPE and safety, and it's a sort of physical safe way of delivering care, but also how on earth are we going to have the capacity across the NHS to not only go back to normal levels of activity, but beyond that, in order of bringing back the increased waiting times that we've got across the nation, and that's huge. And so in the next phase of planning, we are expecting another NHS E&I a letter from Simon Stevens and Amanda Pritchard, which will be the third in the trilogy, it's been described to me, which I'm sure will address exactly these sorts of issues. So we will, alongside the whole of the rest of the NHS, be very much focusing on this in the next few weeks, I think.
Yeah, I totally agree. I think just to respond to that, the reference to the technology that we're using is just an example of assurance that we are, where possible, engaging with our patients in an appropriate way, using new techniques that we've not had before, and the learning from that will be something that we'll discuss in the near future as well.
Thanks for that, Ros. Jane, you want to come in here?
Yes, I suppose just to build further on that, remote first has worked really well during the first phase of COVID, and with Attend Anywhere as video conferencing ability that we're using now across all our teams. That's definitely positive, but from a clinical perspective, clearly remote only isn't going to work for everything, as people have said, but we are using it to be able to initially have consultations, to triage and to identify where we need to prioritise face-to-face consultations, and therefore we can do so safely by having safe capacity just for where it is needed. Just recognising primary care are still pretty much totally remote only, but in the same way are making provision where it's needed. So I think from a clinical perspective, we need to recognise it's not everything. And the second point was that we do have the approach to restoring services is a system-wide approach. It's a clinically prioritised approach, and therefore, we're not doing this alone. We're looking at the needs of the whole community and how, as all the services that contribute to the health and care of our community, we can best and safely restore services. So,
Jane, thank you for that. Can I just ask you? I mean, I take the point completely that's been made that not everything is appropriate for using technology. But having said that, as we go forward into the new normal, would you anticipate that certainly some, I mean, as you just talked about, initial consultations, triaging and so on, would you foresee that we may continue to do those virtually?
Absolutely. And I mean, I think none of us are able to say how long COVID as such is going on for, but actually it is the solution to some of the other things that we've been struggling with. And if we just look at outpatients as a whole across our system, the way you only have to think of it from a personal perspective. You go in to see your GP in order to get a letter to go to the hospital, and then you go to the hospital to see a consultant. Well, we know very well that that's not necessary in all cases. So I think the fact that the whole system has had to only use remote is a really important shift. It's just clearly we won't stay as we are now, but I think remote first will certainly remain in place for a significant length of time, and hopefully we'll then be able to understand how to use it as part of the norm.
Thank you, Jane. No, I think that's really helpful to hear, and I'm sure it's a better way to do some things for sure. So thank you. Okay, if there's no more questions, then thank you for that report. We accept the assurance given by the report, and move on to Sarah for the finance report.
Yeah, thank you, Chair. And Harmesh has already done a really good job summarising the position, but I'll just pull out a few key items. So I'll just start by saying we've added a summary at the beginning of the report, which pulls together all of the national changes that we've been talking about from a financial perspective over the last couple of months. I won't go over them again, but obviously happy to take any questions you've got on those. One of those changes is that our healthcare income largely now is received in a block value. So we receive one payment for our delivering healthcare services. And it is expected that all organisations, so all NHS providers, at the end of April will deliver a balanced financial position, so their costs and their income match. So when we've looked at our block income and we've looked at our costs at the end of April, we have a shortfall in income of 579,000. So we've applied for a top-up. So we've assumed that we will get that additional income at the end of month one, That is in line with all of the national guidance, so that's a reasonable assumption. But it is worth pointing out that our incremental COVID costs that sit within that are 543,000. So what we're saying there is the vast majority of the reason for that top up is that we are incurring COVID costs over and above our normal costs. So there's only 36,000 which relate to our own core business. So that's just worth noting that the majority of that top up relates to COVID. The other thing that we should just pull out is that these arrangements will be in place from April to July. So we've been told that these block income values will continue for that period. We anticipate that it's likely to continue beyond that period of time, but we haven't yet had any updated national guidance on what happens at the end of July. So we're awaiting that. We're also told that for our May reporting, we might get some new updated guidance. But largely, we expect that to be sort of tinkering around the edges rather than any fundamental change at all. So for April, as Harmesh pointed out, we've got a break-even financial position, which is better than we expected when we did our own plan, when we thought we may have challenges delivering our efficiency programme early in the year in April. Just in terms of capital, I'll pull out one final thing. In the report, we mentioned that we were going to be doing a submission in line with our STP colleagues to the regulator on an updated capital plan. So I just want to confirm that we have actually completed that now, and our capital plan value is unchanged. So within the STP capital envelope, ours remains at 1.9 million, which is in line with our original plan. And the STP as a whole has submitted a balanced capital plan in line with the allocation for the system for this financial year. So shall I stop there and take any questions people have got?
Thank you, Sarah. Very, very comprehensive overview as ever. Are there any questions or comments anyone wishes to make? I'd like to congratulate you, Sarah, and your team on the work you're doing and bringing these budgets in as well as you have done is no mean feat. So well done for that. Any other comments or questions? No, in that case, we can accept the assurance given in the report, Sarah, and thank you very much for that. And then I'll move us on to item 10.2, Data Security and Protection Toolkit. This is for approval. And Roz, over to you.
Thank you, Nuala. And actually, it's kind of after the event, so I think I'd use the word ratification. Just to remind colleagues that of things that were suspended in terms of reducing the burden, one of the things that we had a choice about was whether we actually made the toolkit submission around our data protection and security at the end of March, or any time up until the end of September, and that was a kind of a relaxation to just to help. What we took a view at the time, and we haven't met formally as a board since, that we were probably at the peak of our performance because we've been gearing up to have all assurances and submissions and self-assessments in place for that submission at the end of March. As we attained the level of IG training as well at that time, and we know that as our resistant performance levels are really hard to attain, that we took the view that we would submit. So the submission has gone in. The submission has been assessed as significant assurance, which is very important for the board to note. And it's back here really with the information on the report for A, assurance, and B, hopefully for your ratification. There is a little bit of extra in that report just to give the board some understanding about how we have continued to keep an eye on data security as we go through this period, and that we've opened up video conferencing and other kind of sharing across the system to enable healthcare to still be delivered effectively, and we remain well assured that our processes haven't increased significantly any risk. We've got our own data, but that's essentially it, Nuala.
Thank you, Ros. Are there any questions? I see there's Peter. Over to you, Peter Featherstone.
Hi, I don't know if I missed it at all, but what's this national opt-out programme? Because we were asked to accept the extended compliance deadline. So I just wondered what it was and what the extended deadline is.
It was just precisely what I've just referred to, Peter, the extended so the opt-out basically was you can, if you want to, not submit by the end of March. Because of what's happening, you've got, as an organisation, till September. We could have taken that option. It was nationally available to us, but we didn't. We kind of got it out of the way because we'd done all the work. There'd seemed no sense in deferring it. Other organisations may have taken a different view.
Okay, thank you for that, Peter. David?
Yeah, I'm kind of more interested. I'm less interested in the assurance reporting stuff, and that, which is kind of a little. I get why we did it, and that's very sensible. I guess I'm more interested in your last point, which is the ongoing assurance we have that data is secure, because we are increasingly using technology. And we know there was certainly a national worry that the NHS could be targeted for around data security in this period, because our guard could be down collectively. So yeah, I think for the board, at least for me, I can't speak for the whole board, it's are we actually on top of this right now, rather than were we up to speed with it before COVID kicked off, which is kind of what you're saying in terms of our response.
Yes, I think we have reviewed all aspects of the corporate risk register, as well as our kind of systems and processes, David. So I think what I would say is that now we've got a substantial amount of the workforce working remotely. Our attention to service packs and upgrades around our firewall arrangements and patches that the national team send out to prevent people accessing our systems, and also to some extent the way that people work. So how people use hop onto public Wi-Fi and things like that. We are having to watch and manage that a lot more carefully now than we would have done previously. And interestingly, our new head of digital and myself were on a kind of cyber training course a week ago, of which there are some points that we need to have a look at and consider in relation to how we support that agenda as a board, actually. But I'll bring that back into informal board for discussion next month. The key thing, and we'll come on to some of the products that we need to have in place to continue supporting that, is actually the background platforms that we do things like this on, and making sure that we have the right approach and infrastructure to that, which we do at the moment, but we need to make sure that we've got that in place properly going forward. So yes, there's a lot of scrutiny going on, David, with regard to that. I think we did increase, and Claire might be able to correct me there, I think we slightly increased one of our corporate risks to reflect this in the last month, and we've also got again articulated the series of mitigations that we've got in place to make sure we're as secure as we can be.
We did indeed, Ros.
Yeah.
Thank you. Thanks for that, Ros. Tina, you have a question?
Yeah, thanks. It's linked to the point that David's made, really, and I was going to ask it, but I thought it was a bit picky, but now I think no, it's not picky actually. It's on information government training, because we're nearly there, aren't we? And we're at 94% currently, so there's still obviously some staff who are out of date. And given the discussion we've just had, are we confident that those staff who are out of date are going to get up to date in the next month or so? Because it is probably more critical than ever, isn't it?
It is, Tina, and all I can say, and I suppose it's a case of maintaining attention on that as equally as important as anything else that we do. We haven't stood down the requirement to train. We still have the programme of training available to people because it's digital and online, and therefore, you know, at this moment in time, we don't need a recovery plan in place or anything like that because the level of performance is quite high. But it's still part of our performance framework. We keep an eye on it, and again, we'd be escalating primarily through RPC if that training. I know you look at it at QNS as well. That if that training performance started to deteriorate.
Okay, thanks for that, Ros. And if there's no more questions, we retrospectively approve this report, well, ratify it, and thank you for all the work that's gone into it, Ros. Thank you. Okay, we can move on then. Item 11, the governance report. Claire.
Thank you, Nuala. I'm going to focus first off just around the work we've been doing on the board assurance framework and the corporate risk register, and then I'm just giving Peter Phillips a heads up that as chair of audit, if he wants to add anything to the audit committee section, then I'll hand over to him at that point.
Okay.
The reason why we don't have a separate report from Peter at the minute is we haven't yet quite got the timing right between audit committee and board meetings. So the work that we're doing with RMP and with quality and safety, we'll look to try and see if we can improve the flow. So you'll get a separate report from Peter in due course, but we're still working on those timings. So if I go to the board assurance framework and the corporate risk register, the summary report really captures the essence of the work that we've been carrying out. Suffice to say that all of the entries have been reviewed and looked at in the light of the impact of COVID-19, and we have created a separate entry as well in respect of COVID-19 for areas that weren't picked up within the existing BAF entries. So it was really just to check in with board members that they're assured by the work that we've been doing, to take any questions, and if there are any further requests of additional assurance or work that they think we should be including. And then exactly the same process has taken place with the corporate risk register. So we felt that creating a completely brand new risk of COVID-19 the impact is so wide ranging, it actually made more sense to look at our kind of business as usual risks and assess the extra impact of COVID-19. So as a consequence of that, 8 of the risks have had their risk scores increased due to that impact, and the detail of that is set out in the report. But I'll stop there, and I'm happy to respond to questions or take any additional comments that people would like to make.
Thank you, Ros.
Thanks, Nuala. Mine's a comment and a question, I suppose, and it relates to the one of the recommendations, Claire, which I was just having a think about. It's something perhaps we flag now and then consider further. The postponement of the annual review of the BAF is suggested. Until the strategic objectives for 2021 has been finalised, and there's a little bit of a chain reaction in terms of things that have been suspended. So I was just considering that in relation to the fact that we actually have finalising our annual plan suspended because the LTP, the long-term plan for the system, and annual planning requirements have been suspended. So I think that gives us something we need to have a think about, actually, how all of those things impact and what we should be doing with regard to that. So I just, that's caused me an issue when I was thinking accepting that postponement actually it could get stuck if we're not careful. So I just want to look at that one a little bit further, I think, outside of this meeting.
Okay, I think if I can just respond to that, it's the annual review is according to our work plan. It's a timing issue, so it was due at this meeting. Obviously, we've done the review of the BAF in light of COVID, but we started that piece of work around strategic objectives and priorities, but not completed it. Completely take on board what you're saying about the wider reaching suspension of activity. I don't think we should postpone it indefinitely. No. We need to revisit it, because if those longer term regional issues remain outstanding, there's still very much so how do we get on with our understanding of our strategy and our transformation in the light of that gap?
Yeah, and I think that's the issue that it forces, really, Claire, that we actually need to find a way of consolidating that in the current circumstances, rather than the BAF, really. I think it just highlighted the need to just take a view about our objectives.
I absolutely agree.
Okay, thank you. Thanks for that, Ros. David?
Yeah, just jumping in on that specific point, I think we probably need to, through the executive group, look at what you might call, I don't know, interim strategic objectives or some such, because otherwise, you're right, this whole system kind of gums up and stops working, and it just stops making sense. So, increasingly our strategic objectives that the BAF is based on are going to be out of date, aren't they? So we're going to have to do something along those lines. So perhaps we can take that as action for the team, so to speak, to look at that and come back with a proposal.
Thank you, David. Peter?
Yes, I'll come in later on the part 2, which is the audit committee report, basically, points on that. But just sticking for the moment with BAF and corporate risk, the note about all that was on page 5, and about doing the deep dive, and we've just had the discussion on that, so we need to revisit at some stage. If I can just address, may I, corporate risk register. There was one item I just wanted, no need to look at it, but one item I wanted to just underline is the Stoke Stoke Hospital Pharmacy, because we upgraded that risk. I think it's at 16 and needs to get down to 6. Where are we on that is the question.
Nuala, should I answer that question?
Thank you, Steve. I'm sorry, I was just looking for it in the report. Yes, please answer it.
So the reason that rating went up and it'll quickly go back down again was we were struggling with the pharmacist at Stoke Heath not being available, and I won't go into the reasons for that here on the call, but we did manage to source a external pharmacist. So actually we've got more pharmacy support now going into Stoke Heath Prison. So when we come to looking at the risk rating at the consequent quality committee and board, that risk rating will now reduce.
Thanks, Steve. That's helpful.
Thank you. That answers it.
Thank you.
Because I think we were talking, Steve, about relocating it within the hospital, weren't we?
Yes, but we've got the appropriate support now in place. So I think, are you referring to the health wing rather than the hospital? Is that?
Yes.
Yes. Yeah.
Okay, that's fine. Thank you.
Okay, thanks. If you need, I'm sure Steve can provide further clarification if any is needed, but that's helpful to see. Claire, we're back with you. If there's any more questions for you, and if you want to, or do we hand over to Peter for the audit committee section?
I'd hand over to Peter at this point if there are no further questions.
Looks like, I don't think there's any more for you. So Peter, over to you.
Okay, thanks, Claire. Well, I think the report is pretty clear that they've written out there, etc., and given you the key items. Obviously, the annual governance statement, it's still, in a way, I mean, we've approved the draft report. The governance statement, I think the finality of that, Claire, waits for our June the 17th meeting, when the auditors, external auditors have reported, and the ongoing concern basis can then be approved.
That's correct, Peter.
going concern, it looks okay, but we can't confirm that finally. Is that so, Claire?
That's correct, but we did have a good discussion at the audit committee meeting with the external auditors around that, and no concerns were expressed, but we've done the appropriate due diligence, as it were, in terms of having that discussion. Sarah, okay. did you want to come in there?
No, that's fine. I mean, we'll wait on June the 17th. We're still okay on that date. As you said, the accounts have now been prepared. So there's no problem with June the 17th, as I assume, for the extraordinary meeting.
Sarah, did you have a comment?
Yes, just to say that we're still on track. We are still working with our external auditors on the going concern status, but that's the way our accounts have been prepared. There's no particular issues to report. However, given the sort of national emergency, auditors are paying more attention to organisations going concern. So we're supplying additional evidence or supporting documents to our external auditors, but no issues to report. Everything is running smoothly at the moment.
Yeah, thank you for that, Sarah, because just to reconfirm that to our colleagues, there really are no concerns, particularly at the moment. We're just saying it's a process of time, and until we get to June the 17th, we can't sign off on this totally.
Okay, any comments or questions for Peter on that part of the report? I'll just come back to the recommendation. Oh, sorry, Sarah, have you got a further point to make?
Yes, not strictly related, but almost. It's probably worth mentioning it here. At the audit committee, we discussed the fact that we don't consolidate our charitable funds, which is because they're not material in size. So they don't sit within our annual accounts, they sit separately. The point actually I wanted to raise was just to acknowledge that we had received a charitable donation from NHS Charities Together. So we have received the first stage of funding, as they call it, which is £46,000, which we will spend on staff and patient wellbeing. But just wanted to record that this is down to the generosity of all of the members of the public who have been donating to NHS Charities Together. So really gratefully received, and we will absolutely make sure that we put that to good use, and we're considering what that might be. And we discussed yesterday at the Charitable Funds Committee how we might do that. So that's just to record that here, please.
And I think that we could...
From an accounting point of view, Sarah, that doesn't affect the materiality question, does it?
No, it doesn't, Peter.
Thank you.
Thank you, Peter. I'm assuming that there will be further funds released from NHS Charities Together as well as time goes on, and as you know, we will be considering how we want to use those funds, as Sarah just said, for staff and patient well-being. Peter Featherstone. Peter Featherstone.
Yeah, it was just a comment that as and when we spend the monies or receive more monies, as has just been intimated, that we try and make some sort of public communication as to how we use money and our gratitude.
Yeah. No.
What we note within the board, of course.
No, absolutely. I'm sure that will be done. Absolutely, Peter. Thank you. Thanks for that. Right. If there's no further comments or questions, can I just take us back to the recommendations on the paper? And there's a set of recommendations there. Now, I just want to clarify, because Ros, you did query whether we accept postponement of the annual review. Are you happy for that recommendation to stand as it is, or would you like that firmed up? Because the point was made, we can't have an indefinite postponement, but it does say until strategic objectives have been finalised, which is probably a bit loose. I just wonder if we want to look again at that recommendation.
I think, Nuala, and I know Claire will have a view on this, that I think accepting a postponement is inevitable. And as Claire's pointed out, it's self-determining. I think we should just flag for the record today that we need to take some action around strategic objectives to make that action, time scalable, for want of a better word. So I think it's reasonable for the board to accept the postponement, but not in perpetuity, which is the potential if we don't sort out what we say about strategic objectives. So it's a partial, really. I think I would go through. It's subject to, I think, sorting that aspect out.
If we were to record David's suggestion that this is something that the executive team goes away, we could say that we'll report back to the informal board meeting next month on what we think the timescales are, and then that way we'll bring that back to the next public meeting with we've got a timetable and this is what's going to happen.
David, is that what the point you wanted to make?
Yeah, that's exactly what I was going to say.
It. Okay, well, with those caveats then, on section 1 and section 2, are you happy to accept those recommendations?
Yes, Chair.
Yep. Thank you very much. Thank you. Right, next paper, item 12, Strategic Developments Report. Ros, are you presenting this one?
I am indeed. So just a couple of things to say to supplement the content in the report. So the paper's here to provide the board with a summary of some of the significant operational changes that we've been discussing over the last month or so, an attempt to put it all in one place for you as a kind of a stock takeover where we are with some of those things. I mean, some of them are the direct result of national directives, so things that we've responded to because we've been asked nationally to do. So support to care homes, for example, or the anticipatory care planning. And some are a direct result of local solutions that we've had to put into place as the outcome of working with our system partners. So phlebotomy is a good example of that. Some aspects are still work in progress, so they're not done. They're here for information, but we're still working on them, and that work in progress will continue and will shape and influence how we deliver services into the future. So I want board to sort of just be obviously aware of that, and particularly those that relate to our relationship with primary care and our neighbourhoods. Obviously, it's not new as territory for us. Is it something that we've always spent time on and put effort into developing with others? And obviously, we'll continue to do that because it's incredibly important that we stay focused on that. So at the moment, once you've got some information there around how the has set itself up around working groups, etc. We're finalising our internal support arrangements to make sure that we continue to engage to best effect. And I think just finally, I would say that I obviously want board to note that emerging significant developments around an integrated care record proposition in the county that absolutely supports our digital strategy, and that we have made a direct offer around leadership in terms of technical implementation and information governance on an organised set of support arrangements, but obviously that's pending any future decisions that we make to support it and implement it. So they're the key points, Nuala.
Thank you for that, Ros, and I think it's a really fascinating report, this, to see how much progress has been made over the past few weeks and months, and largely as a result of COVID. But it's been absolutely fantastic to see. Right, let me see. Peter Phillips, I think, was first.
Yes, just quickly on page 4, sorry, which is all about Shropcomb's care home and home visiting. Further down the page, it talks about plan to support care homes. Could somebody just explain how that works in practice? Is it a phone in on a regular weekly basis or whatever?
I can take. Do you want me to take that one?
Thank you, Jane. I was going to say other people welcome to chip in with any kind of detail questions. So yeah, please, Jane.
The very pretty diagram helps to explain it a little bit. I can't remember which page that is. But essentially what we're trying to do, and this is absolutely work in progress, and it's purely through grassroots collaboration between our staff and primary care staff. So what we're doing is we have a named contact for each practice. So within our IDTs, there's a specified member of the team local to the practice who checks in on a regular basis with a specified member of the general practice team. So it's a person-to-person contact on a regular basis. We've agreed an approach to prioritising the whole caseload of people in their own homes against the sort of urgent, not semi-urgent and routine approach, because the general practice and our team were using slightly differing approaches to that. So there had been some sort of miscommunication. And then the idea is that we can work with the practice to see how they want us to contribute to the care home work. So there are 3 key aspects of supporting people in care homes that have been introduced due to COVID. One of them is what they're calling a check-in or MDT. I mean, a check-in can just be a call to the care home that we could agree with the practice that we make or they make. But what we're really trying to do is to facilitate a more multidisciplinary approach through a remote MDT involving practice staff, ourselves. We've got the mental health team and social care involved as well. And the idea would be that evolves to meet the needs of the practice. So it may be some practices are already doing this, and we're already working in a very integrated way with them, but that's not the case everywhere. We're also asking the question, would you like us to help with advanced care planning? And there are other areas around infection prevention control, support and training, and swabbing that we've already been doing. So the aim is a more multidisciplinary approach, but it is in evolution at the moment.
Smashing. Thanks, Jane. That's very comprehensive.
That's great to hear. Thank you, Jane. And Tina, I think you were next.
Thanks, Chair. It was on a similar theme, really, around care homes. And Jane, what you said describes the very systematic approach that we've now developing. But the way the paper is written, it almost sounds as though we were doing nothing before the directive. My understanding is, I've asked the question quite a few times, what we giving care homes before the directive. My understanding is that in localities we were working with care homes. Might not have been as systematic as you describe, but it almost looks like we were doing nothing. So.
No, you're quite right, Tina. We weren't starting from nothing, and we had a care home MDT that had been piloted and rolled out in Telford and Wrekin for their care homes, and also care homes includes all residential homes as well as nursing homes. So clearly, where there are no nursing provision, we're already inherently very involved in the nursing home, in the residential homes. So I think what this is supposed to reflect, and it probably isn't clear enough in the paper, is that this is the additional input due to COVID. But having said that, it will plug the gaps and I think work going forward.
Yeah. I just think it's perhaps important for the minutes that we recognise that there was some work going on previously.
Absolutely, and we're building on that. Yeah, we're building on that, Tina.
Yeah.
Thanks for making that point, Tina. Peter Featherstone.
Thank you, Chair. I suppose it's a minor point for the future, really, more of an observation than anything else. And that is when you mentioned, Jane, about us working remotely with part of these MDTs. Obvious sense, we've got a lot of learning at the moment for us to digest across the system in terms of new technology, Microsoft Teams, and indeed we do have a paper later on in the part 2. It was just a query insofar as, whilst we can look after our own usage and deployment of technology such as Microsoft Teams, obviously it would be great if our partners in care homes could also have similar technology so that we could bring in a whole team and share reports in a way that we're doing so today. Are there any discussions that we're having with the care home sector so that we could advance such technologies?
Shall I respond to that one? I'll leave that one with you, Jane. Peter, you know, a very important point about that engagement right across the piece. I think what I would say is that the state of discussion so far extends as far as the local authorities and health. I wouldn't say that we have had the kind of conversations that you would point to that would support a system-wide view about this that includes residential and you know, nursing care homes. We do engage with them as a group, but obviously you know that they're a very kind of disparate group of private organisations, and therefore will be taking and making their own decisions about what they will prioritise and invest in. So I'm not aware of those discussions are inclusive to any substantial extent with regard to care homes, and you know that's something that we do need to explore further, because you're right, we'll miss an opportunity if we can't influence them.
And I think the CCG are exploring that, so I think they're probably best placed to. So there is certainly a lot of work, and we're very lucky because we've got structure partners in care that represent 90% of care providers. That there is a way, and it's probably not something that for StropCon we can do alone, but in partnership with the CCG, that's the direction of travel.
Yeah.
Okay, thank you for that. David, do you want to come in on this?
Yeah, I was going to make that very same point, really, that the because it's known, isn't it, the collective group of independent sector and voluntary sector care home providers is an incredibly valuable opportunity to have exactly that kind of conversation. But I suppose more generally, I think we already knew this, but the COVID experience has shown just how fragmented the social care provision structures are across this whole country, not just in our local patch. And I think we're learning a lot as a country, but also locally, about collective working, mutual aid, opportunities to work across boundaries, etc., which could and should include technology. I'm sure you're absolutely right. But yeah, more generically, I think it just shows if we continue to operate a whole series of separate independent entities that aren't as connected as they could be, then there are going to be weaknesses in our system.
Thank you. Thanks for that, David. Right, Kathy, did you want to come in?
Thank you, Nuala. My question's around the integrated care record. It's really really good to see that we want to have an integrated care record, because it will really help the system. I think my question, Ros, is do we have the capacity within our teams if we want to offer to lead this? And for this, I come from my experience from two other STP areas, and one in particular where we had to put a whole different team in because it just got so big, and I wouldn't want us to lose what we were doing by trying to do across the whole system. I think what we're doing is really important for our patients, and I just wanted your views on that, really.
Yes, I think Kathy, you're right to point out to the I suppose it's one of those moments where you say be careful what you wish for.
Absolutely.
And the experience from elsewhere is very relevant. I think what I'd just like to stress at this stage is that all considerations around the integrated care record will be done on a system-wide basis. There has to be, like all system-wide progression, some form of leadership coming from a part of the system. So we believe that we've got relative leadership strength to take that forward should we sign off an appropriate implementation plan and you know, properly scrutinise the amount of resources that are required for it in order for us to support that as a system action anyway. Leadership and then the actual team that does it, I would say, are two slightly different things. So whilst we might want to lead, we'd be very much leading a system-wide team to do that. And those discussions about actually how we pool our resources are done in the system discussions discussions around the integrated care record. So I would expect us to be able to review and assess what was deemed appropriate resource to implement when we're at that point, and you would see that team being a system-wide team being presented with probably some external support as well.
And would we, Ros, expect all partners to be helping to fund any team that had to be put into place? Yes. It wouldn't rely on us.
No, although I know David and I have had discussions about the kind of relative decision making that's required to share out the cost of an integrated care record, whether that's the implementation or the ongoing cost of it. Those clearly need to, those set of arrangements clearly will be distributed across system partners, but to the extent that it is and how needs to be agreed sooner rather than later, I think. But all of that will be aspects that we can review in due course. I'm expecting that all partners will have access to a full business case and implementation plan to review at the stage that we are asked to formally commit to something. So this is more of a kind of an appetite whetter, I think, in terms of the paper.
David, did you want to add something to that?
Yeah, I'm just to reassure Kathy really that, yeah, you're completely good and very sensible questions, which exactly the things Ros and I have been talking about. But I suppose, so clearly there is a downside to us taking a leadership role, but also I think there's an upside. And if we have the capability and if we are the right people to do it and if it's funded properly, my instinct, it's not a decision, but my instinct is it's good for us to step into leadership in the system space. Because if we're the right people, not just for his own sake, but if we have the right capability and we are reassured of all the sorts of questions you're asking, then my gut feel is it's a good demonstration of our using our leadership capability as one of the members of the system that we work in.
Thank you.
Thank you for that, David. Thank you, everybody. That was a good discussion, and it's good to see all of these service developments coming along. It really is, out of something as terrible as the pandemic have come some real revolutionary changes in the way healthcare is delivered, and it's heartening to see that. Can I ask you to accept the assurance provided by that report?
Yep. Thank you.
Right. Thank you. So I then, if I can move us on to the next item, which is questions from members of the public. Now, I think everybody probably has had sight of one set of questions that came through from a member of the public regarding Shropdock out of hours cover, and I have today seen one other which people may not have had sight of. We'll come to that in a moment, but in terms of these first sets of questions, quite a lot, and I think we will be responding to Jill George outside of this meeting. But I think, Steve, do you want to say something, or Jane?
I think it's actually Ros.
It's me, Nuala, actually.
It's Ros.
Third time lucky.
Sorry about that. Okay, Ros, if you want to say just some initial responses to just give the assurance that we will. In fact, we've already had a conversation with with Jill who raised these questions, and we will be giving a very fulsome response to her in due course. But if you can just, for the purposes of the board and the minutes, give us some initial responses, Ros, that would be good.
Okay. So obviously we just need to acknowledge that we have received a longer correspondence from Jill George and assurance that we will be responding to that separately. But as part of that correspondence, Jill has put a number of questions to the board, the ones that are included in the board papers, and we will be responding to Jill in writing following today's board meeting. But what I'm going to say next also will be on the record as well, so that we make sure that we're publicly accountable. as Jill raises a number of questions there, I've essentially tried to group them into three headings really, so that we don't repeat some of the answers, and it will shorten the response, but hopefully sufficiently cover the ground that Jill's inquiring about. So the first area that she's asking about are the arrangements that we've got in place for the out-of-hours medical cover for community hospitals, and assurances that she's looking for about how we work in partnership with Shropdoc to support our patients who are treated in those facilities. So there's a couple of things I want to say about that. Shropdoc have provided the out-of-hours cover for all of our community hospitals for many years, regardless of the different arrangements that we have in place for in-hours cover, which is either provided by local GPs, so that's the case in Ludlow, Bridgnorth and Bishop's Castle, or directly employed staff, which is the arrangement at Whitchurch Hospital. So whilst there was and has been a change in the Commission's service for the out-of-hours integrated urgent care service in the county, and the timelines referred to in Jill's questions are correct for that, there were no change in the arrangements operating in our community hospitals as a result of that. So those arrangements for our community hospitals did not cease at any point, nor is there any intention of that being the case at this time. It is the case that the service for the community hospitals is now a subcontract within that main IUC contract, as that enabled us to streamline the contract overhead. It's primarily a more pragmatic approach rather than anything else. And should there be any changes to that IUC contract provider in the future, the subcontract would be considered independently to ensure continuity and the ongoing effective arrangements for our community hospitals are in place. The resource and the payment for that subcontract is ring-fenced, so I can give board colleagues assurance that it is ring-fenced. It is a direct payment between ourselves and Shropdoc. It bypasses the commissioners and is around £300,000 a year. So hopefully that gives a broad outline of the arrangements that we've had in place for the community hospitals out of hours with Shropdoc, and that continues unchanged. The second point or area of concern that Jill had raised was around risk assessments and audits for the service that we provide, that are provided to our community hospitals. So a couple of things to say under that heading. Firstly, to assure everybody that there was no reduction in service provided to the community hospitals. There has been no reduction. I think she asked the question, has that been the case? And therefore, on that basis, there was no need for a direct risk assessment to be done. We did seek and receive assurances that the services that we require there and are paying for would still remain in place while Shropdoc went through the change in service for the rest of the county. We've kept our service requirements under regular review and worked together with Shropdoc to address any issues as they arise. So that's kind of business as usual. We can confirm that we contract with Shropdoc to provide end-of-life care in line with our end-of-life strategy, and which includes anticipatory care planning and prescribing. And as part of our quality review processes for the out-of-hours medical provision for community hospitals, we're working with commissioners and continue to work with commissioners to agree a plan for a cycle of clinical audits. So that's the second area, that just as an initial response around risk assessment and audits. The last section or heading really was actually broadening, Jill's questions broaden out into aspects of the integrated urgent care contract and the service model for which we are the contract holder and Shropdoc deliver as the subcontractor. So there's a group of questions that really broaden that out to move away from the community hospitals, but just ask some general questions about that contract, which we have had discussions obviously at intervals very regularly in the initial phase of the contract being set up. And I think Peter raised a request that we actually do bring this back to the contract back to board so we can have another discussion about it in today's context. However, first of all, I just wanted to say that there are arrangements in place to support out of hours primary care access across the county. They are on a county-wide basis, and they're primarily based on the demand that's passed through to Shropdock via NHS 111. So that was a significant change at the processes when the new contract came into place, if board colleagues remember. The arrangements themselves are dependent on the time of day, the day of week, or the weekend day, and where there are different levels of resources placed in different locations at different times based on the demand. So it's quite hard to answer a specific question about what is where, because it depends, and it depends on all of those factors. We can share a summary of those arrangements with Jill separately, and I suggest that we do that. And they were widely circulated at the time of the launch of the RUC service, so that's easily available and shareable with Jill. She makes some specific reference to palliative care patients who are in the community and require support out of hours. And we would agree that that was a key issue which was identified early on with the switch on of NHS 111 and the new arrangements. Shropdock immediately focused on work to address that, because we quickly understood that the healthcare advisors on the call handlers for 111 work very much to an algorithm, and it needed to be looked at, and we've Shropdock instituted some new ways of working to support a quicker response, including training for the call handlers on more effective processes, and set up a separate palliative care helpline in the county. So that was immediately responded to because it emerged as a key issue. This does not mean that delays never happen, however, and the quality of the service, so despite taking those actions, it doesn't mean that delays never happen. The quality of the service is monitored by ourselves and the CCG monthly. We review complaints, trends and thematic reviews, and we consider and apply learning where applicable. Jill makes reference to a 6-month review, which the board again should be, remember. This was conducted and led by ourselves, but engaged all parties, and importantly, Healthwatch for both Shropshire and Telford and Wrekin. So they sat on that review with us. Shropshire Healthwatch also conducted a public engagement exercise concurrently to that review. They focused the conversation on end-of-life care, and were able to check if there were emerging themes relating to the RUC service in general. The report was published, I think, in January, and whilst it did highlight issues which warranted general attention from healthcare providers in regard to end-of-life care, there was nothing specific reported relating to the service that Shropdock provide. But we will signpost Jill to that report for her reference if she's not aware of it. It's possible that she will be. She asked questions about the outcome of the 6-month review. So just again to remind colleagues that the review demonstrated on average patient access times, and this is general, it's not specific to end of life, but on average patient access times have stayed the same or slightly improved in some areas in the county. However, it also indicated that there were 3 changes that were advisable. Firstly, that additional capacity was needed to be put in during the bank holidays because there was peak demand during those periods, and also that we needed to extend the hours that a GP was present in Ludlow and Whitchurch to ensure that equitable access times were maintained across the county. On top of this, there was needed to be extra capacity considered to be built in over the winter period, as not surprisingly, that service, amongst others, experiences increases in demand during that time. The first 2 issues have been addressed independently between Shropdock and Shropcom at no extra cost to the commissioners. So we've looked at the flexibility within the model and addressed those 2 things. The third issue, a solution to that third issue around winter, was not concluded by partners prior to the impact of COVID-19 and therefore is in a holding position. The next step that will be taken at the appropriate time, so we need to determine when we get back round the table to look at this, is for a clinical review of those outcomes and a view to be taken on the the impact of access times should no further resource be available to support capacity over the winter. And Jill asked the question about publication of the outcome of that review, and we would expect that to be made publicly available following the full conclusion of those aspects in due course. And I'll
thank you for that.
Take a breath.
Thank you, no, Ros. That's very comprehensive answer to that set of questions. So, thank you. We have those on the record. Now, I did receive another question. It came through via email, which I'll read out to you. And I think Steve is standing by to answer this one. This is from Diane Peacock, who again, many of us know and who takes a great interest in our proceedings and often attends board meetings. Diane's question is, apart from via teleguidance and online training and written guidance, what ways have clinical staff been deployed to provide clinical support for residential care homes with no nursing presence dealing with suspected or confirmed COVID cases? We did discuss some of these issues earlier on, but Steve, I'm going to ask you to specifically respond to that question now, and we will obviously pass the response on to Diane in due course.
Okay, thanks, Nuala. Yes, it did interestingly get touched on a little bit earlier, didn't it? But just to be really clear, in terms of pre the multidisciplinary teams that Jane referred to, what we have been doing with our locality teams is contacting all those organisations, which included the residential and nursing homes, that we would routinely have been in contact with. So on that basis, we talked to each of those homes to make sure that the residents that were there were appropriately supported, i.e. risks assessed based upon the needs that they required. So during the past about 8 weeks now, isn't it, that our staff, if they've had to have direct contact, they've worn appropriate PPE. If they've needed to support their home, whether that be residential or care, they would have made a judgment call then in terms of whether the staff themselves could be trained. Indeed, some of our staff, because the weather's been quite nice, they've managed to, so a physiotherapy appointment for somebody actually took place outside of the window with the residential care home staff the other side, so that they could then convey that interaction plus intervention that required for an individual. So what I'm trying to say is basically we've maintained contact, appropriate contact with people, and based upon the individual's need, we've made an appropriate intervention or interaction. But I'm happy to respond also in writing to the question as well, to just give a little bit more information. But nonetheless, I think where it probably comes from is there's been anxiety, hasn't there, about those that are resident in care homes in particular, that maybe they've been missed out. But I can assure you that as much as possible, and David probably would reinforce this, the system as a whole is pretty committed to make sure that all patients, all members of the public, wherever they are, receive the right support at the right time.
Thank you very much for that, Steve. And as you say, we will correspond appropriately with Diane Peacock and give her a full response. Okay, if I can move us on. We have committee minutes, which are just there for your information. Q&S and R&P, I think, are there. I don't intend to take questions at this point unless there's anything pressing that anybody wants to raise on those minutes. They are here just for your information. But do let me know if there's anything that you think needs to be raised. If not, and I'm flicking through them, and it's audit committee as well, a very full set of minutes. If there's no comments or questions on any of those minutes, I haven't been notified of any other business, so I'm not aware that there is any. A meeting evaluation. First of all, I just want to say thank you to all of you for your forbearance. We're getting better at this, I think. We're not perfect, it's not seamless, but we are getting better at meeting in this way. So my thanks to all of you for your support and forbearance throughout this meeting. Would anybody else like to comment perhaps as to how we might make things better? David?
Yeah, it was fairly obvious Joe, our member of staff, was struggling a bit with the technology. So I guess there's a little bit of learning. We probably need to do some preparation with members of staff if they aren't used to this kind of technology to make sure it's all working well in advance so we don't get disrupted by that. But no, I sympathised with her because she was obviously something was going on with the sound, wasn't it?
Yes, no, thanks for that. Peter Phillips?
Well, just to thank you, really, Nuala. I mean, I thought it was a very, very big, meaty agenda, and you were pretty well faultless in going through it. So thank you for that. As you say, it does get easier with practice. It's never it always feels a bit more stress than doing a physical meeting. But thank you for that. I thought it went very well. I think this hands up process is very good. It's a great improvement on the thing on the right. Mine wasn't working last time. I think Claire must have fixed the technology because it is now working fine. But thank you very much.
Well, thank you. And if there's no other comments, thank you all. We'll keep practicing at it and hopefully we will get better. Much appreciated. Now, we do have a part 2, but I think we need a break before then, don't we? If all are agreed. And I think we were due to start at about 20 past, but can I propose we start, would 1:30 be enough time for you to have a quick refreshment break, maybe grab a sandwich or something? Is that enough time?
That'll be fine.
Yeah.
Okay, so we'll reconvene at 1:30. Thank you all.
So Louise, if you'd just like to turn the recording off at this point.